And good morning, ladies and gentlemen, and thank you very much for chairpersons. It's a great privilege for me to talk about bariatric surgery, which I think is still in a developing stage. I'm Dr. Yosuke Seki from Tokyo. I have nothing to disclose. Okay, so the similarities, and in the last 70 years, Japanese are getting more and more obese. This is the average BMI, trend in the average BMI. You can see the male gender steadily getting obese, and the female is a similar trend, except the young female. So this is because we have these kind of things. And you can see even worse compared to the United States. You can see the burger with the lot of noodles inside. It's very terrible. And there is big differences in the distribution of the fat and muscle between the Western people and Asian people, even at the same BMI, as you can see. And the typical CAT scan images in the obese patient, the Japanese patient, is the left side apple-shaped obesity. My initial exposure in the bariatric surgery was when I studied in the University of Minnesota 10 years ago with Dr. Ikramidin. So I have both experience of doing bariatric surgery for American people and Japanese people. And in my personal expression, the bariatric surgery for Japanese people may be a little bit more technically difficult because of the too much fat inside. And diabetes. There's a big ethnic difference in terms of diabetes. Now, Western people, American people, tends to be more insulin resistance. They produce a lot of insulin from their pancreas. And the insulin secretion, the Japanese people generally deteriorated insulin secretion from the early beginning of the natural history of the diabetes. So if you see the average BMI among type 2 diabetes patients, the Japanese just 23 or so, the American 30, 34. So it's a huge difference. So consequently, there is a big difference in terms of the incidence of obesity between the American, Japanese, but then if you see the incidence of Japanese, there's a very similar incidence of diabetes between the Japanese Americans. So it's a Japanese Society of Obesity, it's a physician society, set the people with BMI 25-30 as an obesity class 1. So the definition is different. So let's talk about the bariatric surgery. There are a couple of different types of bariatric surgery used today. And this slide already Dr. Schauer presented. It's a trend in the bariatric surgical procedure worldwide. So the sleeve is increasing, bypass decreasing, band decreasing significantly. But then if we look at the procedure prevalence in Japan, 90% of our practice is sleeve gastrectomy. One of the main reasons is the Japan public insurance system only covers the sleeve gastrectomy. But the other very important reason, the stomach cancer issue. There is a high incidence of the gastric cancer here in Japan. So this is our report during the screening, the endoscopic screening using the double balloon endoscopy in the remnant stomach after gastric bypass under general anesthesia and 2 hours and 3 hours. And if you look at the literature, there are reported gastric cancer in the excluded stomach and after gastric bypass. The number is still handful, but not zero. So it's so far the standard Roux-en-Y gastric bypass has not been widely accepted by the gastric cancer medical community up to now. So it's we've been doing the sleep with DJB as a substitute to gastric bypass, mainly for the metabolic purpose. We call the short limb duodenal switch. And it's a combination of the sleep gastrectomy with proximal intestinal bypass with no remnant stomach and DJB effect and a grueling effect, and we preserve the pylorus, so it's less dumping syndrome and less ulcer and less stenosis, which are all of them are the major problem after gastric bypass. And this is the case we recently experienced, the early gastric cancer, the distal sleep after sleep DJB. It's in a stage 1 gastric cancer, resected endoscopically by the endoscopic submucosal dissection. So it's if we prefer to the Roux-en-Y gastric bypass for this patient, I think it's very difficult to detect this region at early stages. So this is the international statement, JSES 2 statement, and they say, metabolic surgery is considered to be an option to treat diabetes in patients with BMI 27.5 and 32.4 Asians. This is specifically very important, specifically for us, because as we say again, we have a numbers of diabetes patients in this lower BMI range. So this is our newly published paper investigating the effect of sleep DJB for lower BMI Japanese type 2 diabetics. And the longest follow-up one is over 5 years. These are the BMI, These are the body weight, BMI, and these are the A1C. As you can see, at least up to 5 years, the average body weight as well as the A1C is pretty durable. And this is the glycemic control pre-op and 1 year. And this is the A1C less than 6% without meds, which is we call the complete remission of diabetes. You can see that 31% at 1 year, and the partial remission 49%, and the composite endpoint was achieved in 22% of the patients, which all of them are statistically significant improvement. And again, the health-related quality of life significantly improved during the 1 year period after surgery. And in multivariate analysis, the fasting C-peptide and duration of diabetes were the independent parameters contributing to diabetes remission, just like a higher BMI patient. So it's again, the lower BMI patient, the earlier intervention, the better results. So in summary, obesity and overweight increasing worldwide, and Japan is not an exception. And gastric bypass is not widely spread in Japan due to the concern of gastric cancer in the remnant stomach. And Asians are prone to central obesity-induced type 2 diabetes and show susceptibility to diabetes at a much lower BMI than Americans. And metabolic surgery for diabetes patients in class 1 obesity is safely applicable and effectively in achieving moderate weight loss and excellent improvement of glycemic control. And this is our hospital. The cherry blossom season is just over last week. And this is our team members. Thank you very much.